My name is Frederico Asch. I am a non-invasive cardiology with expertise in interventional echocardiography. I am director of an imaging core laboratory that participated in EXPAND and many other studies with the MitraClip at MedStar Health Research Institute and the MedStar Heart and Vascular Institute in Washington, D.C. This study was named Mitral Valve Leaflet Adverse Events with MitraClip, NTR, XTR from the Global EXPAND study, expert panel review and recommendations, and it's a study that I performed together with my colleagues Stephen Little, Burkhard Mackensen, Paul Grayburn, Paul Soraya, Michael Rinaldi, Francesco Maisano, and Seival Carr. EXPAND was a multi-center, single-arm international post-market study that enrolled in multiple centers, around 60 centers in the United States and Europe mostly, over 1,000 patients. It's a post-market study with degenerative and or functional mitral regurgitation that were to receive a MitraClip, an NTR or XTR MitraClip. This study was conducted over a one-year period. This started in 2018 when these two systems for the MitraClip were introduced in the market, and were the enrollment finished in mid-2019. We performed a one-year follow-up on these patients that is just finishing right now. The goal of EXPAND was really to evaluate the real-world clinical experience and outcomes associated with the use of the MitraClip NTR and XTR systems in functional and degenerative mitral regurgitation. So one of the things that was being captured on this real-world registry was whether there were any events or adverse events related to the clip itself. However, this was reported by the sites without very clear guidelines on how to define the different kind of adverse events. It would be just a checklist on a case report form without much details. As a result, there were a bunch of different adverse events reported by the sites, but never adjudicated by a central committee. So what we did was to review every one of all these cases and try to adjudicate what kind of adverse event this was and what the outcomes were on those events, if there was indeed what we would call an adverse event. So the idea here was that because this was all site reported and because there were no clear guidelines on how to define these different kind of adverse events, we thought that the nature of leaflet adverse events was very diverse. There was no standardization on imaging, reporting, or echo definitions, and that would have been resulted in inconsistent reporting across the different sites. So we wanted to standardize the definitions, standardize the adjudication by having an independent group of experts led by me, but that included interventional cardiologists, cardiac surgeons, and interventional echocardiographers, all experts in the MitraClip arena. So the generations, as I mentioned before, were XTR and NTR. The definition, so we developed definitions for different kind of etiologies for adverse events. SLDA, or single leaflet device attachment, was one of them, was the one that was found the most frequently. And in particular for SLDA, we actually used a definition, multi-layers of definition. We actually had 3 different criteria: type A, type B, and type C. So, for example, if there was a confirmation of SLDA at surgery or post-mortem, that would qualify the patient. Or if there was echocardiographic or fluoroscopic demonstration of a complete separation between the device and one of the leaflet tissues, meaning the device was only attached to one, that would also be a qualification. And the third one actually had three subcategories, if you want, and they had to meet all 3 of them. Those 3 were new excessive leaflet mobility following a device deployment, color Doppler demonstration of significant MR in the interface between the device and the leaflet, meaning that there was a gap between one of the leaflets and the device. And the third one was failure to demonstrate the diastolic tissue bridging. As you know, the goal of this device is to bring both leaflets together, and by bringing them together, it creates a bridge between 2 of them that gives the 8 shape, if you want, for the mitral valve orifice. So 2 orifices instead of 1 would be present, and that bridge was exactly that point of contact between the anterior and posterior leaflet. So the lack of this bridge right here, that if this was not present, like in a case like this, then that would be also a definition. So those 3 together is what we call criteria, the third criteria, or criteria C. What we found, in particularly in relation to SLDA, was that among the 24 cases that were reported from the sites, we actually could diagnose it in 16 of them, which means 1.6% of the entire EXPAND population. Again, remember, EXPAND was about 1,000 patients, so 16 cases in which we could confirm it. There were 5 cases in which we could not confirm, but we could not rule it out either, and there were a few cases in which we felt strongly there was no SLDA, even being that it was reported by the sites. In addition to SLDA, we actually developed definitions for a few other adverse events, leaflet injury, such as a tear in one of the leaflets, or a perforation in one of the leaflets. I mean, we know that these are things that can happen from the manipulation of the clip and by disrupting, if you want, the leaflets, and then some shape distortions or shape abnormalities of the leaflets that would prevent the proper functioning of the leaflets, such as folding, tension, or pinwheeling. And we had definitions for each of all these situations or conditions. The last one, for which we actually did not find any case, was chordal entrapment. And what this refers to is that situation in which the clip gets tangled in the chordae in such a way that at least one of the 2 leaflets, if not both, do not get attached to the clip. So the clip cannot work as it's supposed to work, because rather than being grabbing both leaflets, he's only grabbing one, and on the other side maybe grabbing the chordae, or it's just completely tangled in the chordae and never gets to grasp the leaflets. We call that chordal entrapment, whether it was a complete entrapment or a partial entrapment. Our findings are, first of all, that the leaflet adverse events are rare events with MitraClip, with NTR and with XTR. For the leaflet injury events, the tears and perforations, we actually found that only in 0.4% of all the cases. There were 11 cases that were thought to be leaflet injury by the sites. We could only confirm it in 4 of them. 2 of the 4 had a tear and also had SLDA. So again, it's a very rare event, 0.4% of all the cases. When it comes to SLDA, we found it in only 1.6%, as I mentioned before. And when it comes to the chordal entrapment, we could not report it on any single case, although we know that from an imaging standpoint, chordal entrapment and SLDA sometimes may be very difficult to differentiate one from the other. The other things that we found, so this is all very consistent with the rates of leaflet adverse events reported in previous series, such as the TVT registry or the Access EU study, which were also under 5% for all this. So that I think it's an important point. We found these similarly infrequent for the primary MR and the secondary MR, or functional and degenerative, and we found it relatively similar for XTR and NTR in general. We looked at the anatomic characteristics that could that could predict whether these events would happen in patients. What we found is that, for example, those patients that had SLDA were more likely to have complex mitral valve anatomy. And that means wide gaps, degenerative leaflets, a very wide jet, and a few other characteristics. That happened in 30, so one of those characteristics was present in 31% of the SLDA cases, while and in none of the leaflet injury. And the presence of this in the overall expand was much lower of this mitral valve anatomic complexity at 18%. I think those are important findings. I think a couple of other things that we found related to leaflet injury, for example, was that in all cases in which we did find leaflet injury, there was significant residual mitral regurgitation as a result of the tear or the perforation. That only happened in about 25% of the cases of SLDA. And that is probably because when you have an SLDA on a clip, you can still keep going and implant another clip that eventually would take care of the significant MR anyways. That is important. The other thing that is important is that both SLDA and leaflet injury were happening more frequently in patients that had multiple attempts to grasp with the clip. So if you know, one of the characteristics of these clips is that you can grasp, and if you're not happy, you can ungrasp and grasp again, and ungrasp and grasp again. Well, the more of these graspings you do, the more likely you are to have adverse events, whether it's leaflet injury or SLDA. So that is another interesting finding, and I think those are really the important findings we had. Well, I think leaflet adverse event is something we fear as interventional cardiologists and interventional imagers. We do not want to get there. We know that is not good for our patients. We know there is a chance they will end up having a surgery or even dying. So this being the first comprehensive review of mitral valve leaflet adverse events with the MitraClip really gives some good insight. This is the first time that a panel of independent multidisciplinary experts gets to review a series of these things. This is resulting in some definitions that we hope are going to be standard moving forward and will help in the field for our colleagues to be able to define events on a more consistent manner. But it also brings light of the safety of these devices, because these leaflet adverse events are significantly rare. So I think it is important to highlight those points. New standard echocardiographic definitions. We hope it's going to improve consistency and diagnosis of adverse events, and the fact that the incidence of leaflet adverse events is actually quite low.